So, very good afternoon. Welcome to next session. And yeah, this is, I think, very interesting topic. How to manage, how to treat patients with calcified bifurcation lesions. I think this is something what we have to manage in cath lab safe, and in which way, what is really important, we will discuss during this session. With me is Beatriz, Gerald, then Dr. Catakoglu, then Dr. Chen, Dr. Jorge, I think he's not here, and Dr. Mamas. So we start with the first presentation from Dr. Masaaki Okutsu, the development of 3D calcification images for PCI by coronary CT calcifications. Welcome.
Okay. Good afternoon. Now my presentation is about the development of 3D calcification images made by the coronary CT imaging. The beginning of this calcium story was from this conversation. The great mentor, my great mentor, Dr. Sunao Nakamura, said me that if calcium is evaluated by CT, it's so great. So I asked, usually impossible, but I can see through calcification in CT. So this is a departure of the long calcium journey. Now, this is a bifurcation curve. So I would like to focus the bifurcation calcification. There are two discussive issues in PCI for calcified bifurcation lesion: necessity and effectiveness of atherectomy devices. From my data, the bifurcation area calcification is one of the predictor of the circumflex ostium narrowing after the crossover stenting. So this area calcification is very important. And then this might be the mechanism. The opposite side of the calcification is easily to shift the carina to the circumflex and after the stent implantation. So this calcification, if possible, this calcification should be averted by the atherectomy devices before the stenting. However, sometimes we meet such a case. As you can see, the left main bifurcation area have much calcification, but the LED ostium have poor guide wire bias to the calcification side. So after the rotor blade, 2.0 millimeter rotor blade, the LED ostium calcification had no contact of the rotor blade. So this case is a little bit difficult, but now not so good option for these lesions. Then from our data, less than the 0.5 millimeter distance from the vessel wall to the guide wire is a good predictor of the good operation of the after the orbital atherectomy system. So like this, and evaluation of the necessary and efficacy is very important for the bifurcation PCI before the procedure. So at first, we try to measure the calcification thickness. This is very challenging. In EBC 2019, we reported a new calcium measurement algorithm by using this formula. And then, 2022, we reported 3D calcium images created by this new calcium measurement algorithm. And then, last year, we reported the 3D virtual guide wire bias simulation program by using this 3D calcium model. However, this calcification model was created by using the CT density number. So this method have some limitation, and then actually this prototype guide wire bias simulator program have a little bit the complex steps. So it's not so easy to make this image. So I changed my mind in this year. I tried to make a 3D calcification image by using the deep learning system and auto detection of the calcification. Then this is a 3D calcium image by using deep learning technology and a new virtual guide wire bias simulation program. Now, actually, this red and green line is estimated guide wire bias, and the green segment is a good contact. The red segment means there no contact to the vessel wall. So very easy to understand the guide wire bias. Then I checked the accuracy of the guide wire bias simulation program. 17 vessels of the 16 cases was evaluated, and then actually there are not so high score, but the good image of the calcification of the vessel was 71%. So, but now under the developing. Then the 57 calcified segments of the 12 vessels was evaluated of the correct estimation rate. This number is maybe good. The correct estimation correct guide wire bias estimation was observed 89%. So, and this score is I think acceptable. I would like to show you the case. This case is 43 years old male, and diagnosis was unstable angina, and AVF was 40%, under the hemodialysis. As you can see, the patient had 011 bifurcation lesion in the left main. I checked the CT image of this case. As you can see, the left main bifurcation area have much calcification, and the guide wire bias simulator line shows the good contact to the calcification in the LAD and the circumflex also. So I think I thought for these cases, rotablator maybe work well. So I did the rotablator by using the 2.25 big bar. And I was shown also good guide wire bias in LD ostium and LD proximal part. And after rotablator, the right side, you can see there good ablated area was observed in the LD ostium. Next is the circumflex. The circumflex also the good contact to the guide wire bias simulation. And in IVAS, the circumflex ostium and the proximal part have a good guide wire bias, and after rotablator, the good ablated area was observed in the ostium and the proximal part. So I directed this both region by using the 3.0 cutting balloon, and then the drug coating balloon, and then this is the final angiogram, maybe the acceptable region. So now, and this program is still under development. So there are some future issues. Well, first one is much deeper learning to precise the calcium and the vessel imaging, and improvement of the accuracy of the guide wire bias simulation is also necessary. And then actually in this time we checked the LAD and the circumflex cases. So no, there was no RCA case. So and RCA should be also checked, and by using this program. The assessment of the bias or for the non-calcified vessel wall is also important, because we should avoid the guide wire, the vessel wall injury by the atherectomy device. Thank you very much for your attention.
Yeah, thank you for a very nice presentation. Do you believe you can measure exactly how deep the plaque is? No, it's 1 or 2 millimeters. Can you estimate this?
The calcification depth. Actually, the one point is in the deeper calcium and superficial calcification is a little bit sometimes difficult to evaluate by CT. So sometimes difficult to the position of the calcification. However, the proximal part in the calcification is very big. So this point is the deeper side or superficial is not so big difference for the heavily calcified lesions.
So, congratulations. I think this is really, really novel work. So congratulations to both you and Dr. Nakamura. In terms of your computer simulations, though, I think one of the key things when you're thinking about wire bias will very much depend on the nature of the wire that you use. So if you use a very flexible wire, you may get very different wire biases than if you, say, use a rotor stiff wire. So does your model take into account the characteristics of the wire?
Thank you very much. Yes, difficult question. There is a difference of the wire stiffness by using the support wire and the soft wire. However, both is metal. I think the not so big difference is one point. Another point, it is so difficult to identify the difference to the guide wire bias. So maybe it is a limitation of this software now.
But it's something to think about, because I think the wire bias of, say, a rotor stiff wire, which is what you're looking at, you know, whether rotor ablation is going to be effective, will be very different from a floppy coronary wire.
Thank you. Thank you.
Thank you very much.
I had one question. So basically, your wire bias is also determined, or you could also determine your wire bias by just watching the IVUS contact. Isn't that true? If you get through a lesion the IVUS, you can have a very quick assessment of your wire bias.
Thank you very much. The important point is the pre-procedure evaluation is possible by CT, but intravascular imaging is impossible. This difference is very big. So if checking during the procedure, intravascular imaging is maybe the more correct, but pre-procedure situation, we want to know how to effective by using the atherectomy device. This is sometimes very important.
But I also understand that you don't have orbiter yet.
Yeah.
So with orbital, probably you have to rethink your strategy and the criteria. Mm-hmm. So is there any future, when will orbiter atherectomy come to Japan?
Orbital atherectomy? Already available.
It's already there?
Yeah.
Oh, sorry.
Yes.
Then you are quick for this one. But did you compare this analysis?
Still not. But in the future, issue.
Okay.
And a question. Congratulations for your presentation. And once you detect the bias, how do you recommend us to solve it? Maybe by gently push or pull of the wire. Maybe doing performing several runs. What do you recommend us?
Now, this program have recommend simple contact. So such a detailed difference is maybe I think that not so different to decide So here is the contact point. So sometimes the aggressive because for the calcification. If non-calcified vessel wall, take care. This is important information.
Thank you.
Thank you very much.
The next speaker is Hyeon-Cheol Gwon. He's going to talk about the challenge of calcification in coronary bifurcation lesion. Thank you.
Yeah, thank you. Oh. Okay. So I really appreciate for inviting me to this meeting, and I come back after 3 years absence. Nice to be back. So let me start with a case of calcified lesion and stable angina. The 81 years old female patient presented with the left main bifurcation with the diffuse LAD lesion. And you can see a severe calcification both in LAD and circumflex. This is Medina 011 case with a severe calcification. So, sorry. This is a very nice case for me to the elective rotablation. So we did a rotablation for LAD and circumflex. Actually, the rotablating the two branches are not a big issue. Actually, we only use one wire at a time, but there is very low risk of side branch compromise during the procedure. This is after the rotablation. You can see some filling defect in the mid LAD, possibly dissection, possibly calcification. So we did a ballooning for the LAD and circumflex, and we found the lesion is very well prepared for the stenting. So simply put 2.5 by 32 millimeter stent with LAD and pull back the balloon and applied high pressure for the dilatation calcification. Another stent proximally, additional ballooning, and high pressure ballooning proximally. So we did a circumflex ballooning afterwards. Please note that the LAD balloon is in position all through the procedure afterwards, even during the side circumflex stenting. This is a preparation for the TAP technique. So I did a kissing ballooning actually. So I did a kissing ballooning before the circumflex stenting recently for the TAP technique because to the better preparation of the lesion. So after kiss, the circumflex was okay, so we need to understand. So I try to call it a DK tap. So positioning of the circumflex stent is very important to meet the proximal end of circumflex stent to the inferior side of the main stent, and put the stent in 14 atmosphere and pull back and apply high pressure as recommended by EBC guideline, and finalize with kissing ballooning. So actually, I found some under-expansion of the LAD lesion, so I applied again with the kissing ballooning, but with the higher pressure for LAD, low pressure for circumflex. So I did 3 times of kissing ballooning in this case. This is final result. Oh, sorry. So this is the final result. The circumflex ostium is widely opened in this angiography. But I was from the LAD. The stent was well expanded in circular, and the stent crine is very short, less than 1 millimeter with the correct positioning. Okay. But in circumflex, actually, the stent was well expanded, but still elliptical. This is a problem with eccentric calcification, so this cannot be not well treated in most of cases. So if we, 83 months later, actually, patient presented as unstable angina. You can see mid-LAD, stent edge retinoscus. You can see some disease in the circumflex ostium. Fortunately, FFL was not significant, so we decided to live there. But this is because of the eccentric ellipticity of the circumflex lesion. This is final result. Actually, the standard of expansion is the most challenging point of calcified lesion. This is well studied, but I like to mention that eccentric calcification is the outcome is worse than concentric calcification in terms of diameter gain and the stent eccentricity index. One of the challenging points for calcified lesion. So, what's the clinical outcomes of calcified lesion in general? It is associated with the worst outcome in terms of MACE and all-cause mortality, TLR, and stent thrombosis. What about the calcified lesion, COBIS-2 bifurcation lesion? COBIS-2 registry, we found that moderate to severe calcification in the 21% of cases, and this group was associated with a higher event rate in terms of target lesion failure and target lesion revascularization, and numerically higher cardiac death or MI. But the COBIS-2, only 15% the patient was treated with the second generation DES. So I pulled the analysis of COBIS-2 and 3. That this is a new analysis, and I proposed the match score matched in the 1,700 patients for one stent and second generation DES. Actually, can I use this? No. Okay. So in the target lesion failure, we have one first generation calcified, first generation non-calcified, second generation calcified, and the second generation non-calcified. You can see second generation DES is working better than first generation DES, but still calcification is a problem even in this second generation DES era. So actually, during the analysis, I found that the additional side branch calcification is associated with the high risk of target lesion failure, cardiac death MI, and target revascularization, which was found in 35% of cases. So in the calcified lesion, if you find another additional severe or moderate calcification side branch, we have to deal with it and prepare for it. Okay, lastly, I like to talk about the second two-stent technique for calcified lesion. And in COBIS-3 registry, you can see a TVF is better favored for the one-stent technique in non-calcified lesion. The difference is quite comparable between one-stent to stent in the calcified lesion. This P4 interaction is quite significant. This is true for TLR rate, and the P4 interaction is there is a trend for significance in cardiac death or target vessel MI. So to confirm this finding, I did a propensity match analysis for one-stent, two-stent technique in calcified group and non-calcified group. So in calcified group, you can see the target lesion failure, cardiac death MI, target lesion revascularization rate is quite comparable between one stent and two-stent technique, and this is not true in non-calcified lesion. Maybe this is a registry, this is hypothesis generating. Maybe two-stenting technique is better working in the calcified lesion compared to one-stent non-calcified lesion. As you know about the definition study and definition 2 trial, and they found that the more two-stent technique is better working in complex lesion, but it is not true. In simple lesion, the one-stent technique is better. I am happy about this idea, actually, but I'm not happy about the criteria for complex lesion. It's just very small letters down there, but there are 2 major criteria and the 6 minor criteria for complex lesion, but each of the variable was not proved in any clinical trials. So I'm not happy about the -3 bifurcation angle less than 45 degrees, and the 6 main vessel lesion length more than 25. It is indicated for two-stent technique. I'm not happy with that. And the main vessel plaque burden is also important in addition to side branch osteal plaque burden, as we published several years ago about it in JACC to predict define the predictor of side branch occlusion. So anyway, I present some clues of the advantage of two-stent technique and calcified, moderate to calcified lesions. So this is the beginning, I think. This is the findings for COVID-2 registry. I'd like to finish the procedure, the presentation to have time for discussion. Thank you.
Yeah, thank you. Great data. What is the main factor suggesting double stenting is better than calcified lesions, as you show it here?
Yeah, so actually, this is too early to answer that, but still in calcified lesion, the lesion preparation or MLA, MLD, the optimization is less perfect, especially not only in the concentric calcification, but also the eccentric calcification. So maybe gaining the larger lumen is more difficult with one stent technique. This is one hypothesis.
How often do you use two rotablators, two burrs? I mean, 1.5 is very small. We start usually, you need 2.0 to achieve some ablation.
To gain the actual, the proper stent expansion, I think the portal artery ratio should be around the 0.5. In this patient, actually, the vessel is very small. So usually for the stent expansion, I usually use 1.75 at least.
I mean, the problem that we see, you used angiographic criteria, and we talk about calcification and we see CT. And if you do a CT scan or you do IVUS or imaging during the procedure, the calcification is more sensitive, or the detection of calcification, than in this in the angio and even in different angio systems. So the problem that we have, I think we talk about one thing, but we have different ways to detect different loads of calcium.
Sure.
That is just a thought that we need to find angiographic calcification, but that is different when you use maybe enhanced imaging.
Now, I think CT is really sensitive. I am very impressed by the first speaker, but if it is exaggerating or overestimate the amount of calcification, and I'm not sure the clinical impact of that kind of calcium in the clinical outcomes. So actually, the only thing I like to know, I like to believe is that at least moderate and mostly severe calcification has an impact on the clinical outcome. This is what I'm focusing on. That is the napkin ring calcification more than 5 millimeter in length in IVUS, and the bilateral parallel calcification, so-called severe calcification is the matter. So I think that's only, we have to find out, but I think that will be has a clinical impact.
In your experience, calcification is the same outside the bifurcation or in the bifurcation? That means the morphology of this calcification because of the bifurcation?
Yeah, actually well studied by the doctor. The pathological study showed the opposite side of bifurcation. Abluminal side is prone to lipid core and also calcification because of the inflammation.
How often do you use IVL to approach this left main lesion?
I'm very sorry to say it is. The IVL is not available in Korea. Shameful.
That's next questions. Some questions?
So if we have, thank you very much again.
Thank you.
So the next speaker is our co-chair woman. Beatriz will talk about bifurcation lesion preparation in a calcified setting.
Thank you. So I'm going to introduce my speech talking about general calcification and why we need an algorithmic approach. I think we treat more and more older people, and age is a predictor of calcified lesions, and also all these patients has a lot of risk factors that also are related with calcification. Now we have more tools to analyze these vessels, so we have more information about calcification. And also we have more devices, new devices, and better devices. And also we have more companies involved, so we have more education and more knowledge in this field. So it's the reason that 1 year ago, with the European APCA and Euro4C group, we prepared this consensus document that is one of the others, is not the best. And in this consensus, you see the right part is when something doesn't cross. If it doesn't cross, you need rota or laser. So, but if you go to the left side, I think it's more interesting when something crosses the balloon or intravascular imaging. So then you have imaging, and the first question is, you need plaque modification, yes or not? And then, according to the intravascular imaging, you can also add some information about calcium morphology. And that is important to choose the device. So for yes or no, we have two scores, by OCT and by IBUS, and it's not the goal of this presentation to talk about this, but we could say yes or not, we need plaque modification. But after that, we have few information, but we need to have more studies to fill all these gaps. For example, in an uncrossable lesion, we know that rotablation and laser are really good. The difference between rotablation and laser, with laser you can use the same wire. For rotablation you need the dedicated wire, so this is the difference. And now we know by in stent stenosis under expansion, IVL, it seems really effective. Also laser, we have some studies saying that it's quite effective. In long diffuse disease, rotablation is useful. We know because we have a lot of experience, and Orbital also in the USA has a large experience. But maybe for deep calcium and concentric calcification, IVL shows better results. But we have a lot of things that we don't know. Calcified nodules, we don't have a lot of information. In tortuosity and calcification, always is a risk. All devices have some risk in tortuosity when we combine tortuosity and calcification. So when we talk about bifurcation lesions and the impact of calcification, we add two complexity. One is calcified, and one separately is bifurcation lesion. By studies intravascular imaging, we know that spotty calcification, according to these studies, is a predictor of side branch occlusion. So we need to prepare this plaque very well before to implant the stent. In this CT trial, they found similar things. They found that the calcified plaque in the proximal segment of the bifurcation was a predictor of side branch occlusion. But in fact, when we talk about plaque modification, we don't have data. We have registries, retrospective, we have some cases, but we don't have a lot of information in this field. When I have a review in the PubMed, I found some trials about atherectomy therapies in bifurcation lesion. So we have this sub-analysis of the prepared calc, and we have the orbital retrospective registry. So in the orbital retrospective registry, also they have the limitation because they analyze the calcification only by angio. And they define the bifurcation as this. A bifurcation lesion was defined as any lesion extending past the side branch. So they did a match, a propensity score match, so they didn't find any difference between the two populations. That means non-bifurcation, bifurcation, severe calcified lesions treated by orbital. But then when we see, they didn't find any difference also in dissections, perforation, embolization. So they found that they take more time to treat bifurcation lesion with orbital, but they didn't find differences in complications. But also, let me see. But this in red is important because they don't have data about the angiographic core to see what was about the side branch after orbital in bifurcation lesion. And when you see the 30 days maze, there was a tendency opposite to the bifurcation group. That means maybe there is a risk of side branch occlusion using orbital, or maybe it's because the bifurcation lesion is more complex. But also the myocardial infarction was nearly significant in the orbital bifurcation group. When you see the other, the prepared calc, this was a subanalysis. But to me, the first step is quite not really good because they randomize cutting balloon, scoring balloon versus rotablator in severe calcified lesions. I think we need these trials to demonstrate that maybe cutting balloon is not enough when you have a severe calcified lesions. And inside of this, they analyze the bifurcation group. So the bifurcations were 110, more or less half of the population, and 111, also maybe half of the population. So we're affecting the side branch, half-half. And when you see the side branch was not treated by scoring balloon or rotablation, was only 3% of the cases. So mainly they treat by plaque modification the main branch. So they found significantly by using balloon technology, a scoring balloon or cutting balloon, there were more compromise of the same branch comparing to rotational atherectomy. There were more dissections and significant stenosis in the side branch. And that was significant in this retrospective registry. And in the group of cutting balloon, scoring balloon, there were large dissections comparing to the rotational atherectomy, and the crossover from the one group to the other was 18%. This is a case. I think in the last registry, they used a cutting balloon. The mean size was 3 millimeters. In my experience, to LAD, we undersized the cutting balloon because in my experience, we don't see a lot of dissections as in this registry. But it's the all information we have. This is a case that we did last week. So was this lesion was an LAD. The ostial LAD was an all stent that was by angio expanded, and there was a true bifurcation lesion that by angio shows some calcification. So we decided to do IBUS to analyze this under expansion in the ostial part, and also to analyze the calcium morphology in the bifurcation level. So when we tried to pass the IBUS, the IBUS didn't cross the first lesion, so we decided to delay it with a small balloon. But when we delayed with the non-compliant balloon, 2.5 and 3.5 in the ostial all stent, you can see that the balloon was not well expanded. So we decided to do IBL 3/12, all the pulses, because it was really hard to open this stent, to then start working in the bifurcation lesion. So after this, we analyzed, and you can see distal to the bifurcation was an eccentric calcification. You can see at the level of the bifurcation was not really calcified lesion, but proximal to the bifurcation was a severe calcification with an inner lumen that was small. So we decided to do a rota-cut strategy. That means start using rotablation. And the rationale behind that was a diffuse disease with severe calcification that was concentric and superficial, and we thought that combination was quite good. So you can see this is after rota-cut. You can see the cuts of the rota and the cutting, and at the level of the bifurcation was similar. This is the rota. So this is the final result after dracoluting the balloon at the level of the bifurcation. We did pot and kissing, and this is the final result using dracoluting balloon, 2 dracoluting balloon, 3.5 in the ostial part. So in my experience, you can use a rota-cut or rota in bifurcation lesions, but it's really effective if there is no tortuosity. To me, when there is tortuosity, there is some risk the rota and dissection. But when there is no tortuosity, I think is a really good and effective tool to plaque modification. This is the final eyeballs. You can see distal to the bifurcation, at the level of the bifurcation and proximally. So to me, actorectomy therapies in bifurcation lesion have some positive point. The ablation might reduce the plaque burden at the level of the carina. Ablation might reduce the risk of side branch occlusion. I think it's the first election in uncrossable lesion, ROTA. And ablation might reduce the risk of dissection when there is no tortuosity. But on the other hand, I think ablation need a contact. So it's important the bias of the wire. Also, it needs a dedicated wire, and it's not possible to protect the side branch with another wire, and also sometimes there is a risk of distal embolization. So now we are going to talk about IBL and bifurcation lesion. I think IBL is increasingly used because it's safe and effective as plaque modification device in non-bifurcation lesion. As a balloon technology is easy to use, and also it allows us to work with two different guide wires easily and simplifies the procedure in this context. Also, I think we know that IBL is really safe and effective when there is concentric and thick calcification. Also, it's really effective in undilatable stents, and we have some initial promising data in eccentric and nodular calcification. This is a retrospective trial analyzing. This is to sum up. There was a left main bifurcation lesion, but only 25% of the cases. The presence of nodular calcification in left main was 42%. They used intravascular imaging in all the cases. They combined rotational atherectomy and IBL in 20% of the cases, and you can see that was safe because the procedural perforation was really low, procedural dissection was 0, and the events that follow on were really good. But it's retrospective information. Also, you can see the cracks. The cracks were seen by intravascular imaging in 82% of the cases. And this is a case report that is starting. We have more and more information that IBL could be effective in nodule calcification. We have similar data, but I think is retrospective of cases. And this is a research correspondence that when they compare calcified nodule and no calcified nodule using IBL, they didn't find any difference. So they recommend to use additional pulses when you treat these more complex scenarios. This is only the final example, was a live case also. You can see this is a bifurcation, was 111, and we used because was not really severe lesions, but the patient was really symptomatic, but EFFR were positive in the both branches. Okay. Sorry. You can pass the next slide. I'm sorry. Yeah.
They have to restart the PowerPoint because the video crashes the program.
Okay, you can see this. You can see by IBUS that was at the level just behind the bifurcation was the calcified nodule, and at the level of the diagonal branch was not calcified lesion. So we decided to use IBL 3 millimeters in the calcified nodules, and the operator decided to delay the diagonal branch. In my opinion, it was not necessary, but that was the strategy. And then because of that, they use this nano decay crash technique that is really interesting, but maybe in that case was not necessary. So IBL in bifurcation lesion have really positive points. Is able to protect the side branch with a second wire. Is not required of a specific wire. So the way that it works is really effective in deep calcification. I think there is not the risk of distal embolization, and I think it's a balloon technology, so it's easy to use. The only thing in bifurcation lesion that maybe these technologies could avoid the balloon technology that shift the plaque or shift the carina. So maybe this technology is better more than cutting balloon. And I think in tortuosity also is a limitation. And also in long and diffuse disease, maybe is not the best the device to start, maybe in combination with a rotational atherectomy. So this is the same chart that at the beginning, that maybe in calcified nodules and bifurcation lesion, maybe IBL is promising, but we need more data. Thank you, and sorry for the presentation.
Thank you very much for this overview of the views of the 4C group. Just one thought. Basically, you have 4 modalities. Laser, nobody has available almost, so we must put it in brackets. It's only in US. Yeah, you have. Do you use it, or is it with the peripheral guys mostly? No, you can.
4 times a year.
Okay, 4 times a year. So, but what I want to point out, we have ablation techniques, and then we have modification techniques that create space. And I think when we plan that, we should really look into the mass of calcium and rather choose the technique that ablates when we have massive calcium thickness as compared to maybe a technique to disrupt the surface and get a balloon open. What do you think about that? CT planning.
Yeah, I think also in my experience, when you do IBUS in long lesions, you can find all the combinations. You can find eccentric, calcified nodules, and also thick calcification. So in most of my cases, I use a combination of devices, and it's safe and effective. Sometimes I start when there is a diffuse disease and it's difficult to advance material to use with ROTA, and then I combine with IBL. In the past, I used cutting balloon, and now I change cutting balloon for IBL in that situation. But I think a combination of devices is really good.
Okay, thank you, Patrick. One last question.
So the other day we had a beautiful presentation by Akiko Mehara, and my takeaway from that presentation is that these nasty rectangular erupting nodule of calcium, I mean, when you see that, you say, oh, I will be in trouble. Because even if your illustration with after the lithotripsy, you could see that you split the things in 2, but after the stent, it was still at that side something major. So my impression is that when you look at the orbital, when you look at the rotablator on these erupting calcified nodule, they do very little, as a matter of fact. They make a small cut in, but not very impressive. I think the lithotripsy is probably, IVL is probably the way to go. But do you have any advice about what will be the criteria to say, okay, that's the moment of the stent? In your case, there was a nice split in the middle of the calcified nodules, but do you have another criteria to say now it's the time to stent?
I think it's one of the questions when you do plaque modification and you do intravascular image after that, is enough to implant directly in a stent, or you need more plaque modification? In general, in calcified nodules, sometimes you see dissections just at the base of the nodule. That means it's not well treated, and you expand the calcified nodule to the basal wall, and you do an eccentric stent implantation. I think at this moment we don't have an answer in calcified nodules. I know that maybe orbital, because goes distal to proximal, in that situation, when the calcified nodule is in the circumflex, maybe could be effective. And also IBL, in that situation, we have case report, so we don't have strong data at this moment.
That's correct. So we in our center in Bad Kreuznach, we have now collected, I think, 1,200 patients with 1 year follow-ups and comparing all three modalities. So either rotablation, orbital, or IVL. So
because also we are learning that there are different calcified nodules. Not all the nodules are the same. Sometimes you dilate a nodule and you expand the nodule and said, okay, and you treat another nodule and it's really thick. So there are differences between nodules.
Yes, yeah, Ali's got a really nice paper around that, looking at the difference between eruptive versus non-eruptive nodules and the MLA that you can achieve and whether it's compressible and so forth. So yeah, I mean, they vary. We also published a paper more recently with a group from India looking at the relationship between eruptive, non-eruptive and IVL susceptibility, and particularly at the fracture of the base. So I think we're still learning.
You start to say something interesting there about your 1,000 patient there. Could you continue?
yeah, we 1,200 over 1,200 patients, and interestingly, we see there is increasing number of need for two approaches. So you just make a channel with rota, and then you go with IVL, or you start with orbital, and then you on top go with shockwave. This is definitely the need in daily routine. Okay, thank you so much, Beatriz. We are a bit late, so we go now to online presentation from Nicolas Amabile. I think it's recorded. 1 year outcome of IVL procedures for unprotected left main PCI. Data from LILI registry.
On the behalf of my colleagues from the France-LILI registry, I would like to thank the EBC for the invitation and the opportunity to present this data. As you know, intravascular lithotripsy represents now a very valuable option for the treatment of severely calcified coronary lesions. However, yet the device use appears safe for de novo lesions management in large vessels, the data regarding its use in unprotected left main lesions are scarce. So the present work aimed to assess peri-procedural and 1 year outcomes post-intervention in these patients. This work is a retrospective analysis of the France-LILI data. France-LILI is a prospective national academic registry from France that evaluates the safety and the effectiveness of adjunctive IVL procedure in PCI for all comers patients. All the clinical data have been centrally collected in a standardized CRF. The angiography data pre and post PCI have been analyzed with QCM methods. The primary endpoint of our study was the incidence of target vessel failure that was defined as a composite of cardiac death, MI, and target vessel revascularizations. The secondary endpoints included the procedural success, defined as a successful stent implantations with less than 20% of residual stenosis and without relevant complications and angio. We also identified and collected the incidence of peri-procedural complications such as slow flow, dissection, or vessel perforation. All these endpoints have been evaluated and confirmed by an independent adjudication committee. This slide shows you the workflow of our study. The France-LILI patients were 500 all-comers patients with IVL and PCI from 34 active centers from France, who were included between November 2021 and February 2023. We identified 78 patients among this cohort with left main IVL and PCI. 7 of these patients got previous CABG, but 71 patients got no previous CABG and represented the unprotected left main group. On the other hand, 432 patients got IVL in another site than left main. 22 out of these 432 patients got previous CABG, but the 410 remaining patients got no CABG and no left main IVL, and then were defined as the control group. This slide shows you the baseline characteristics of both groups. You can observe that patients from the unprotected left main group were older, got more frequent chronic renal failure, and a more severe extent of their coronary artery disease compared to the control group patients. But there was no other significant clinical difference between the two groups of patients. As you can see on this slide, the number of lesions treated by IVL was more frequent. There was more frequently more than one lesion treated by IVL in the patient from the unprotected left main group, which makes sense. But the incidence or the prevalence of intrastent restenosis among the treated lesions was much higher in patients from the control group compared to the patient from the unprotected left main. And despite the lesion location was of course different because 100% of the patients from the UL left main group got left main disease, we did not observe a difference regarding the degree of calcification according to the Means classification, the lesion length, or the degree of stenosis by QC at baseline. There was more frequent lesion predilation in patients from the control group compared to the unprotected left main group, and but there was no higher use of true IVL catheter. However, the first catheter diameter was larger in the patient from the left main group, which makes sense, and so the maximal stent diameter was also higher in these patients compared to the other patients. But we did not observe any difference in terms of lesion post-dilation, as the percentage of patients with post-dilation was roughly around 56% in both groups. The total stent length was similar, and there was no higher use of true stents for PCI in these patients. As you can see, the procedural success was comparable among both groups and ranged from 93.1 to 94.4%, so no significant p-value there. There was also no higher risk of periprocedural complications in the unprotected left main patients compared to the control patients, and as you see, actually there was no notable periprocedural complications in these patients. Overall, we can see that the incidence of these periprocedural complications was extremely limited in this cohort of patients. This slide shows you the one-year clinical follow-up of a patient, and you see that the incidence of the TVF over the first year was 9.9% in the unprotected left main patients and 9.5% in the control groups. Once again, no significant statistical difference. There was no difference for the TVF as the composite endpoint, and there was no difference in terms of individual endpoint. As you can see here, we were just surprised to observe that there was a higher incidence of significant bleeding events in patients with unprotected left main compared to patients from the control group. And finally, this Kaplan-Meier curve confirms that the occurrence of TVF over the first year was not significantly different when the log rank test was used, and remains very limited over time. So in conclusion, ladies and gentlemen, these results support IVL as a safe adjunctive technique in routine clinical practice for patients with unprotected left main. Immediate and one-year clinical outcomes suggest comparable results between left main and non-left main lesions, which is extremely promising. However, we acknowledge that longer clinical follow-up is required to assess the long-term outcomes of this patient. And I thank you very much for your attention.
Nicolas, thank you for a wonderful presentation. Any questions from the panelists?
Thank you for your excellent speech. Do you think is there any difference of the IVL on the bifurcation lesion and non-bifurcation lesion? Because we use the IVL in the bifurcation lesion, sometimes the content of the IVL balloon may be not tight as tight as the IVL balloon used in the non-bifurcation lesion. For example, in the lemon bifurcation, if there is a discrepancy in the lumen diameter between lemon and proximal LAD, which size of the IVL balloon should you choose?
Thank you very much for the question. Mostly in the France-LILI registry, regarding your last question, the operators adapted the size of the IVL catheter on the distal branch or the main branch diameter. So in case of left main to LAD treatment, the catheter size was decided based upon the diameter of the LAD. But in some cases, some operators use two catheters, very few cases, but they use a bigger catheter in order to treat properly the left main.
May I ask about the size of the left main? 3.6, is it the nominal diameter or the QCA diameter that you have given?
No, the 3.6 was the size of the maximal size of the catheter, it was not the reference vessel diameter by QCA. So that's what I told to the previous panelist. So in case you adapt, you use the same catheter to go for LAD to left main, of course you will have like a smaller diameter catheter compared to the diameter of the left main. So which explain, I think, the results.
Yeah, but this is kind of the final diameter that was used in the left main, which seems to be very small. I hardly ever put a balloon below 4.0 in a stent, at least in the German population.
Correct, but I think that the strategy of the operators was to use a IVL catheter, go for, let's say, the catheter was mostly between 3.5 and 4, and then the post dilation that was applied in almost 56% of the cases. So in this case, in case of post dilation, the diameter of the diameter of the balloon was adapted to the diameter of the left main. So
my mistake is that was the size of the IVL balloon.
Correct.
That you give. Ah, okay. Not the final.
No, it's not. It was definitely not the geographic size of the left main.
Then it makes
okay, there's one more, a final question, please, because we are quite late.
Yeah, we in India use a lot of IVLs, and particularly for the calcific nodules. But one thing I must tell you that in the categorization of the calcific nodules, the non-eruptive as against the eruptive does give a good result with the IVL, but the non-eruptive does not give very good results as far as the IVL is concerned. Vis-a-vis, if you talk about the long-term analysis of the stenting in such cases, the non-eruptive, the outcome is poorer as compared to non-eruptive calcium nodules.
Yeah. Okay, thank you for your remark. Thank you so much, Nicolas. And we go ahead and we have Dr. Singh with his final presentation, left main calcified lesions. Which tools for which lesions, and single or combination?
Okay, thank you very much. I think the previous speakers have done all my job, so I think I'm going to stop talking now. Especially Beatriz, she just covered all the things that I was going to cover. So I'm actually going to go quickly and go to my cases where we can really illustrate what the speakers have really discussed. So what tools to use, whether you use single, one versus the other versus combination. And we I have orbital, rotational, laser, anything you want, we have. So, and we use and we have experience in those. So these are my disclosures. So I'm not going to discuss algorithm. We're going to talk about left main calcification. We'll discuss aorto-ostial, the shaft, and distal bifurcation a little bit. And then we'll talk more so about, what do you really see? And we'll, most of the speakers have covered superficial, deep, nodular, because we've become smart now with calcium. The problem is you become smart, but what do you do, right? And if you do we have data? And I tell you, we don't have much data in left main right now with all the tools that we are using. And then patient characteristics are very important in terms of decision making. I think we haven't covered those. So people who have low ejection fraction, who are in shock stage, females we haven't talked about. I believe female arteries calcified are different than male. I really believe that. And people, especially look at the people who are on steroids. You try to do atherectomy in those and you'll see what happens in these people. And we have bad dissections, bad perforations, and vasculitis. So we got to treat patients differently. We got to look at them, and we're going to treat each calcium differently, and left main is no exception. So I'll share two cases, how do you treat the first one and the second one, and we'll go over the third one if we have time. So I'm not going to go over, everybody's familiar with this. Beatriz covered all these things. You guys know how to select. This applies to left main really also, whether a lesion will yield or no. With a balloon, when to use balloon, high pressure balloon, OPNs, or specialty balloons versus orbital. And the reason I'm going to show the algorithm is, if you see here, we have included imaging in every scenario, and then nodule is included also. But we haven't really included whether eruptive or non-eruptive, which are very differently treated. We really still don't know a good treatment for nodules. We really don't. And then after we've done all these things, we still image. Because I think it's very important for you to be specific about that. You got to reassess before you do definitive therapy, to reassess whether you fractured either it's a dissection or you fractured the plaque or the nodule, or even with a balloon to take two angles to see if your balloon has yielded or not. Otherwise, you're going to run into problem. And then Dr. Gwon showed this case of circumflex where it's eccentric. Eccentricity index in BVS was very important. In calcium, it's even more important, and that's the data shows. So I think it's very important to understand, especially in nodules, that you've done a good job. So I'll go over this. There's two things for selection in left mains. I tend to use in distal left mains, and if I have to use atherectomy, I tend to use orbital, because there are some theoretical things in orbital, especially people who have low ejection fraction. They actually have slightly higher risk of reflow. And then with rotational atherectomy, actually, when studies have shown that if the CFR, before and after, and the microparticles are a little bit more bigger in rotational, actually your ejection fraction, the wall, is actually down for probably 2 hours until it recovers. They don't have reserve, and those are the patients you want to use support. And CFR studies show similar sort of things. It doesn't really change that much. But if you see orbital, if you did flow studies with orbital, your CFR actually improved right away after orbital. So it's a theoretical benefit here, and you can see it could have implications. And also the way the centrifugal thing goes, it allows you to have blood flow, allows the microparticles to go rather than being occlusive. And for left main distal bifurcations, these are important also. Pacemaker need, obviously I use orbital a lot, and we really don't ever put pacemakers because there's not real need for pacemakers, because the way it kills the red cell and adenosine is released, rotational actually is much more destruction of red cells with release of adenosine not really that vibration sense, is more adenosine release from the red cells, and more happens with rotational than orbital. So osteal lesions are important because osteal lesions, are highly calcified. The ones that are calcified are usually nodules. Even in left mains, this was an RCA study, but the left main study that showed that at least about 50% of them are nodules. I think we need to treat them differently, and IVL is very, very important in that. And especially if you're using orbital or rotational, make sure your guide is coaxial, and make sure if you're doing orbital, go distally, then come back. Because if you start doing and the nose cone doesn't engage the thing, you can dissect the cusp, and people have got dissected cusp and cause severe AI, so you have to be very careful. So I'm going to jump over all these things here. I'm not going to talk about nodules. The only thing I will talk about nodules is that rotational atherectomy is very poor in nodules. Orbital, like Beatriz showed, has promise. So I'm just going to jump over this. I'm going to show the cases real quick here. Gender differences, I was going to talk about. If you see rotational and orbital, males and females are very different. There is high complication rate when you do atherectomies in females. So it's very important to know that when you do selection of patients and when you use the algorithm, and this was actually shown in the orbital, actually in the IVL data, that actually there was no difference between male and female, and the complication rate was actually much lower. You'll see here outcomes were much, and to these papers, Sky actually said that IVL may emerge as the first-line therapy for females. So there's a study called Empower CAD that's being done now, only study to be done in females, prospective study just to illustrate that point. So people have covered this. So 84-year-old, how do you treat elderly patients, female with bad disease? Patient has all the vascular disease. You can imagine ST elevations in AVL, AVR, suggest left main disease, troponin leak, and this was the EKG, badness, and then this is your case. So if you look here, obviously, flows are not very good, bad calcium, subtotally occluded left main. We tried to wire it, we wired it, but the microcatheter, actually we were planning to do atherectomy, but microcatheter won't cross into the lesion, so we actually had to put microcatheter right at the tip into the lesion, and then since the orbital is more, Viper flex wire is more friendly to wire than the rotor wire, we were able to actually take that down, and then I quickly pushed the orbital through the lesion and come back. So when you orbital, actually what it does is when you push and you pull back, it actually cuts the inner wall, and you push a blade, it cuts the outer wall. So I did that, and then you'll see this is what it looked like. So I thought, I was happy I created a good channel. Then I put a balloon in there and it won't expand. It was that sick of a calcium, and you know what it was is I put shockwave after that, and you can see that it yielded very nicely, and this is my imaging, and I'm marking the ostium there with IVUS. And when you pull back, you see I gutted the outer wall with the CSI, and I did nothing to the nodule. It was a big nodule in the ostium of the left main. So a bad dissection, you can see the dissection there on 3 o'clock, going from 1 o'clock to 5 o'clock, and then bad nodule. So then shockwave actually took care of it. We looked at it, and then we put a stent in there, covered, make sure you don't have geographical miss, protected the circ with a balloon, and now the artery looks happy. And now you can see LED. So combination in these scenarios and understanding what is happening is very, very important. And so you can see now we talk about eccentricity. Look at this. This is perfect placement at the ostium with imaging, and then eccentricity is as circular as they come. You cannot get nodules to be that circular. Your aim should be to do that. And I think for us to treat these things, it's very, very important that we understand this and we use combination technology to really get these kind of results. So it's very, very important. I don't have much time here, but I'm going to quickly jump over this thing here. I'll show you this case real quick also. Bad case, bypass, all the bypass to the left system is occluded, core-dominant circumflex, big, LAD has a stent, right has a bypass, but this is the only tiny right coronary artery which has a bypass that's only open. So we actually went from the groin, took a picture. We had a very, very hard time wiring into the LAD and wired into the circumflex. and balloon wouldn't cross. So we actually did CSI into the circumflex, pulled that wire. It's very difficult. It was such a resistant lesion. I didn't know where the lesion was, actually. It was so resistant, nothing would cross. And then I was able to then see the CSI won't go, and I'm pushing, and you're not supposed to push, but we are. There's no other option. So we did that, and then I was able to wire the LAD after that with the supercross wire and went into there, and then we exchanged the wire, and I did CSI, pulled the circumflex wire, wired into the LAD. And you see we have a decent channel, but still nothing really would go, and the balloon would have problem yielding here. So we shockwave both limbs. You can see, now you can see the calcium is broken. You never saw that. It's like a filling defect. It looks like clot, but it's literally a broken up calcium that you see on angiogram. And we IVUSed it here. And you'll see on IVUS here, when we pull back, you actually saw nodule in the LAD ostium, and you saw 360 degrees of calcium in the very distal part of the left main. That's why it was so tight. And now you can see it's all broken up from shockwave. And if you look at the circumflex, when we pull back, there was no disease in the circumflex. It was an ellipse, but the lumen was so big. So we really now know exactly what type of calcium it is. We've treated it, and now we know where to stent. So we stented the LAD, just protected the circumflex angle, and 5-fab balloon, and you have this result here. So I really believe that understanding the pathology, understanding the type of calcium, and then using those things to really decide based on imaging is probably going to be the way to go. But I think our next speaker is going to tell us that we need trials. We need whether these things work or no. Thank you very much.
Thank you. Great case, definitely great cases. What I would like to tell you, you finally tried, in first case, you tried to cross with the microcatheter. Wire was inside, microcatheter couldn't cross. So you was very lucky to cross with orbital. I personally performed more than 150 orbital atherectomy cases, and in around 5% of cases, you are not able to cross with orbital atherectomy. So you have to remove everything to rechange and to take either laser or 1.25 burr to rotor blade. This is one point. And second point, probably next year we will get a new catheter from a Shockwave company, so we can give energy proximally to the entrance of the plaque of proximal cap, and this will be probably very good help to manage such subtotal calcified lesions.
Yeah, I think that laser does that actually. The only way a laser does that, laser actually gives you this. The problem with laser is if you do it in saline and you keep on doing it, won't do anything. Okay, so that thick calcium laser is not that good, but if you do laser with a little bit of contrast, it actually works as good as shockwave does. It really breaks the calcium so that you can use a balloon and then use shockwave if you want to. But it is very similar to what they are designing, but laser really works for those scenarios. So if I have this problem with crossing, then we do. The other thing is that Viper flex wire that they have now, they used to be the old Viper wire, which is actually stiffer. So they took it away. So usually, if I don't cross, especially with rotor too, sometimes even 125 burr won't cross with a rotor floppy wire, I'll exchange it to rotor extra support, usually goes. I usually change the wire, it usually goes in both scenarios also. So that's what I do first before I change to the other modalities. So, but that's very, very good point.
Thank you.
Thank you.
I think that the last talk was not a talk, was an open discussion about future trials, because I think the calcium field is a really amazing field. I think that despite we think that we need intravascular imaging, we don't have enough data behind this. There is a trial one trial in calcified lesions regarding intravascular imaging, and I think more and more, for example, the consensus document the last year it needs to update it, because now we have more information based on intravascular imaging and regarding the devices that we use based on that. So we need a lot of trials, but I want to know your opinion about that. Any opinion?
Yeah.
Well, I don't think you need trial data when we've got 20-year-old data from Gary Mintz to say that intravascular imaging helps us see calcium, and the sensitivity of angiography in both determining the presence of calcium and the extent of calcium is very poor. So in my view, intravascular imaging is the starting point. I think in terms of trials, I don't think device A versus device B trials are particularly useful. I would argue that perhaps the trial should be in the algorithmic approach and randomize use of the algorithm. So you could say that, you know, you sort of do, operator does whatever he feels like versus an algorithmic approach, and then see whether with the algorithmic approach you get a better outcome. That's what I would do for trial.
Yeah, and one point is that this is an economical burden on the cath lab, an average European budget. So planning should focus on selecting the most efficient algorithmic approach from a pre-planning standpoint. So we come back to, I think, the first presentation, that if you have a good CT up front, we should decide between ablation or or facilitation. I would divide rote ablation, atherectomy, as opposed to those methods like IVL that do not remove, but just facilitate. And that should be, I think, the focus of a trial. Use the least and the most effective.
Yeah, but I'm agree with you. I think the intravascular imaging should be more used. For example, in Spanish centers in 2022 and 23, less than 12% of the procedures of the complex PCI underwent with intravascular imaging. Now I moved from the public health system to the private health system, and we have to fight with all the insurance companies to explain them why we should use those techniques. And I presented recently a study to them, to the Corporation of Insurance in Spain, in which I showed the data from 2023, in which in Spain we performed 4,605 left main procedures, but only 322 with IBUS guided. And we compared the data from those patients with the other patients, the outcomes at 1 year. Just the hemodynamic or the interventional procedures money we have to spend to redo the procedures. For the patients who underwent IBUS guided PCI, we spent 4 million euros. For the other arm, we spent almost 20 million euros. So I think it's a useful tool, but for me, we have to do two things. First, we should convince our colleagues to use it and to explain and to be aware that it helps us to the procedures and it helps our patients. And second, we have to report more cost-effectiveness studies, because we think the health is the primary thing, and obviously the primary thing, but we have to know how to explain to the authorities or to our colleagues how to use it.
Yeah, I have the impression that multi-slice CT scan will be the destabilizing factors, but also the most common use. I mean, certainly with the photo counting, I'm impressed by the quality of the pictures. It's phenomenal. It's getting close to IBUS. You know, it has a resolution of 111 micron. And then with the multi-cavity, you have basically the blooming effect, which is disappearing. So you see really the structures very, very clearly. And if you look at the use in the European community, it's at least in trial that we are doing, it's now 32%. 32% as a first diagnostic tool. So if you combine the fact that it's penetrating the diagnostic phase more and more, the fact that the quality is getting very impressive. I think not this year, but last year with Bruno Farah in the Clinic Pasteur, we planned a main stem only on the multi-slide CT scan. And the multi-slide CT scan was showing at the end of the main stem completely circular calcium. You cannot imagine how much. Now, we didn't discuss too much. We said we start, if we can cross with the lithotripsy, was not a subtotal, that will be the way to go. And then we activate 10 times. And then after that, the stent went like a charm immediately into the vessel. So I think multi-slide CT scan, if we come back next year and the year after, etc., that will be penetrating the field in a very great way. Yeah.
Thank you. Thank you. We are going to finish the session. Thank you to all the colleagues and to the participants. Thank you.